at the end, we can have time for discussion. So I'm going to be talking today, kind of an overview of community water fluoridation. So I'm going to start right at the beginning, right? What is fluoride? Well, it's a pretty abundant mineral in the Earth's crust. It's found in rocks and soils, and it tends to be found at the highest level in mountainous regions. What fluoride does for enamel, and I'll have a diagram on this in just a couple of slides, is it actually replaces the hydroxyl ion. So the enamel crystals go from hydroxyapatite to fluorapatite. And what you end up with is a harder, physically harder enamel that's more resistant to acid demineralization. Ingesting too much fluoride when permanent teeth or when baby teeth are forming, I can actually lead to something called fluorosis, and we'll go into that a little bit. To date, there really has been no evidence for any toxicity from intentionally fluoridated water or salt or milk. But very high levels of fluoride can be acutely toxic and even fatal. And we're talking extremely high levels, like a young child eating, 10 tubes of high fluoride toothpaste. So not something that you would encounter on a normal basis. So since I might be the only dentist on this call, I'm not sure, but I thought that I would go over a super simplistic review of how cavities form. So first of all, dental caries is the fancy clinical term for tooth decay or cavities. So whenever I'm talking about caries, that's what I'm talking about, cavities. Um, Basically, we need a trifecta in a way of three different components to end up with a cavity. So first, we have bacteria. We all have bacteria in our mouths. Several strains of bacteria, several species of bacteria have been linked to dental tooth decay. Some people have more aggressive bacteria in their mouth, meaning that those bacteria will take the tiniest bit of carbohydrate, which is the fermentable substrate component that you see on this slide, and metabolize it into an enormous amount of acid. And other people, more fortunate people, have bacteria in their mouths, but those bacteria tend not to be so robust in producing acid and causing problems and causing cavities. And then finally, the third component would be that susceptible tooth surface. So teeth that are very close together, very tight contacts where things are constantly getting stuck and the bacteria can hide. A very common spot to get tooth decay is actually in the deep grooves or kind of fissures or pits that anatomically occur on certain teeth, especially permanent molars. And when it comes to a fermentable substrate, we're not just talking candy, really any carbohydrate. So a lot of parents don't realize, first of all, how much sugar is in juice. They think juice, they think fruits, they think vegetables, they think it's healthy. Juice is healthy. Juice is one of the biggest culprits when it comes to cavities, especially in very young kids who are constantly sipping on a sippy cup or even a bottle with juice in it. Fermentable substrate can also be goldfish crackers or pretzels. I mean, anything that has carbohydrates, and especially things like goldfish crackers and pretzels that get stuck when you feel that stuff getting stuck in your teeth on the, especially those in those kind of grooves that you have on your molars, those are troublemakers. So again, susceptible tooth surface. So there's anatomical factors, those teeth that have deep grooves, pits, or even teeth that grow in with enamel defects. Those are going to be more prone to tooth decay. Orthodontic issues such as crowding, very, very tight together teeth. Baby teeth, actually, ideally, we should see space between every single tooth in a young child's mouth. And only the permanent teeth really should be touching each other. But a lot of kids are not fortunate enough to have that space, and they end up more prone to developing cavities, especially where those teeth are touching tightly together. They'll get the kind of in between, or what we call interproximal tooth decay. Again, we can have issues with our enamel. So sometimes enamel maturation and mineralization is disrupted because of traumatic events in early life, such as a traumatic birth or illnesses, high fevers, or other medical problems in the first few years or months, even of life, when those permanent teeth are starting to develop. Sometimes there's genetic components. So there are a slew of genes and ongoing research to figure out why certain people actually have these, less well calcified enamel. And sometimes that enamel can even look different. It can look yellow or brown. And you can see it kind of flaking off. It's called enamel dysplasia or enamel hypoplasia. And there are certain actual conditions too, like osteogenesis imperfecta, dentinogenesis imperfecta. These are not very common conditions, but they certainly can have a tremendous impact for those individuals affected. And then we have normal enamel without fluoride exposure is more at risk for developing decay than enamel that has been exposed to fluoride, because once again, that fluorapatite that forms when the hydroxyl ion is replaced by fluoride makes the enamel harder, and it increases the tooth's resistance to that acid attack from the acid that bacteria are secreting. And then we're going to take a little deeper dive into this, but enamel fluoride exposure can happen through systemic or topical. So this is a diagram. I'm citing the source that I got it off of the internet here on the bottom left, but basically showing how, incorporation of fluoride into enamel actually changes the crystal structure. So it makes them more symmetric, as it says on the bottom here, and they stack better. So it's a tighter, harder enamel that's been once it's been exposed to fluoride. So you end up with stronger teeth with shallower fissures. Again, fissures are those spots, those deep grooves in teeth that are really prone to tooth decay. So if you can shallow or harden out those, basically crystallize inside the fissure with fluoride, you're going to be very, very much more resistant to tooth decay happening. So fluoride has both systemic and topical effects. So when we talk about water fluoridation, community fluoridation, most of the effect, not all, because if you think, you're drinking water, right, or you're eating salt, or you're drinking milk that has fluoride in it, it is touching your teeth, and some of that fluoride is also going to be secreted back into your saliva, which again is coming into direct contact with tooth enamel. But for the most part, community fluoridation really goes through the systemic route of delivering fluoride. So what that fluoride does once it's ingested is it actually incorporates into the enamel of the permanent teeth that are still forming while they're mineralizing still in the tooth follicles in the jaw bones. And so it's strengthening that enamel before the tooth even arrives in the mouth. And again, there is some topical effect from the fluoride that's present in saliva, or the fluoride that gets incorporated into the dental pellicle, which is like the coating that we all have on our teeth. Topical fluoride, on the other hand, so these we're talking about at home topical fluoride in the form of toothpaste or rinses, but also professionally applied, so higher concentrations of fluoride in professional level rinses, gels, varnishes, foams. I mean, we have a myriad of ways to apply topical fluoride these days. That is applied directly to the enamel present in the mouth, teeth that are already erupted and present in the mouth. And topical fluoride, because it is such a high concentration of fluoride, has been shown to have some bacteriostatic effect. So now we're going to talk about how fluoride became an integral part of oral health. So this is kind of like a history story here. There was a dentist, Dr. Frederick McKay, and he went out, this was in the good old days, right? In the late 1800s and early 1900s, he went out and hung up a shingle. He graduated dental school and said, I'm going to open a practice in Colorado Springs, Colorado. And in Colorado Springs, there was this epidemic of this mysterious disease that they called Colorado brown stain. So Dr. McKay noticed that about 90% of the adults he saw that were raised in Colorado Springs have this mysterious brown stain, this Colorado brown stain on their permanent teeth. But adults living in Colorado Springs who had not spent their childhood, they were not raised in Colorado Springs, did not have this mysterious brown stain. Dr. McKay, being a dentist, happens to notice that these not so pretty, quite frankly, ugly brown stained teeth are extremely resistant to tooth decay. These people were not, they had ugly teeth, but they were not getting cavities. So the big hotshot at the time in the dental world was G.V. Black. And if anyone is on this call and has gone to dental school or thinking about going to dental school, you will hear tons of things about G.V. Black. He is one of our founding fathers of modern dentistry. So G.V. Black accepts Dr. McKay's invitation to come west to study this weird dental disease, this Colorado brown stain. What the locals in Colorado Springs were blaming the staining on, a variety of different things, from eating too much pork to drinking contaminated milk, and thinking that the water was possibly contaminated with something, or that there was maybe too little calcium ion in the water. But they really, that water contamination theory really stuck with people. So it starts to gain momentum. When a town in Idaho sees they switch their water supply, and then all of a sudden they started seeing the prevalence of Colorado brown stain, then switch their water supply back and see the incidence of Colorado brown stain and its population declining. So we're starting, everybody was starting to point to the water, but not really clear on what it could have been in that water. So a serendipitous new technology really led to figuring out what was going on here. There was an aluminum company, the Aluminum Company of America in Bauxite, Arkansas. And this aluminum company started to get blamed for the rise of Colorado brown stain in bauxite residents. And there was no Colorado brown stain seen in nearby towns. So the aluminum company got defensive and said, "Hey, wait a second, we're not putting anything into the water that would cause any problems." So they actually sought out the answer to what was in that water, trying to absolve themselves of the blame that everyone was putting on them. And they used brand new technology of spectrophotometry, and they identified that the water in bauxite had very high levels of fluoride. Now, again, this is like spring water, right? Coming from reservoirs and from springs. So Dr. McKay, our dental friend in Colorado Springs, uses this new technology and finds high levels of fluoride in the towns with high prevalence of Colorado brown stain. So, aha, they figured it out. So then our public health warriors came on board, and they figure out how to use this new technology so that they can measure fluoride more specifically and down to pretty low levels. And they started serving water supplies throughout the United States. And what they ended up doing with all of this hard work was that they kind of found this ideal fluoride level when it comes to, again, this is all naturally occurring fluoride levels, but water with about 1 part per million fluoride in it, again, naturally occurring, ends up being the really kind of the sweet spot, right? So we talk about therapeutic index, where it's just the right amount to see an effect without causing harmful effects. So 1 part per million people drinking fluoridated water, there was some mild fluorosis, so not the ugly brown staining at all, maybe like a little white fleck here and there, but not that much fluorosis actually. But meanwhile, these residents in these towns with 1 part per million fluoride in their water were seeing less tooth decay than neighboring towns. So they figured out that 1 part per million is kind of the ideal amount. That's that's the therapeutic index that we want to be out as far as if we're going to add fluoride to the water. And as a side note, in 2015, the American Dental Association did reduce that to 0.7 parts per million. And we'll get into that in a little bit as to why that was reduced. So then come the epidemiological experiments. In 1945, Grand Rapids, Michigan became the first city in the world to intentionally fluoridate its water supply. And then the NIH and the National Institute for Dental Research study over 30,000 children in Grand Rapids and followed them out for 15 years. And what they saw was that after 11 years of implementation of this water fluoridation, caries prevalence declined by more than 60% in children that were born and raised with access to fluoridated water. So a tremendously dramatic, successful public health initiative. And as a side note, water fluoridation is not an expensive thing to do. So in today's money, it's about $1 per person per year to fluoridate a water supply. So there are parts of the world who wanted to get in on this dental benefit, but fluoridating water supplies was just not feasible for a variety of reasons. So they looked to fluoridate their salts, and salt fluoridation continues today, especially in parts of the Caribbean and Central America and in Europe. A lot of Western Europe does not have fluoridated water, but they do have fluoridated salt. So in 1955, Switzerland became the first to fluoridate their salt. And as I mentioned today, about 85% of domestic salt consumed in Switzerland is actually fluoridated. Germany has about 67% of its salt fluoridated. And in the Caribbean and in Latin America, more than 100 million people ingest fluoridated salt. Some countries have more than 90% of their population consuming fluoridated salt. And salt fluoridation is actually even cheaper. Not that water fluoridation was expensive, but it's less expensive than even water fluoridation with, about a penny to 3 pennies per person per year. So milk fluoridation is done in a few places, mostly in Europe. Unfortunately, milk fluoridation does not have a lot of evidence to support that it really is effective in reducing tooth decay. Probably part of that is because fluoride binds to calcium. That's how fluoride ends up in your teeth and in your bones, because it has an affinity to calcium. As a side note, if you have a young child who has gotten a hold of some high fluoride toothpaste and eaten an entire tube of it, one of the things at the Poison Control Center will advise you to do is have the child drink milk, because the calcium in the milk will bind up that fluoride and allow that fluoride to be excreted. So the calcium binds, so the bioavailability of the fluoride in milk is probably not as great as it is in water or salt. But some schools in Europe do supply fluoridated milk in both powder and liquid forms, and it's also more expensive. It's about $3 per person per year to fluoridate milk. So for those of us living in non-fluoridated areas, such as most of the state of New Jersey, um, pediatricians and dentists and pediatric dentists, as a subset of those, will often prescribe vitamins with fluoride in them. And this is just a chart of the current recommendations for fluoride prescription. So if the person is drinking fluoridated water that's fluoridated at a level of 0.6 parts per million or higher, then we don't give any supplement. And you can see by age, it kind of goes up. The reason that we give less to the younger kids is because the enamel on those permanent front teeth is still forming. Those front teeth usually erupt around age 6, where you can see on the bottom left there, where we start giving the maximum recommended dose of fluoride to these kids. What we want to try to avoid with fluoride supplementation is that fluorosis. And again, it's that mild fluorosis. It's little like white spots or white lines in the enamel, but still, if we can avoid it, that's what we want to do. And ideally, we do want to perform a risk assessment, because this is a prescription now we're entering the realm of prescription medication. We want to make sure that we're not, that we're really identifying those individuals that are at high risk for dental disease and prescribing accordingly. So times have changed. Prior to 1990, when studies were done on community fluoridation, the caries were reduced, almost really 50% across the board. And as I mentioned, those first studies done before we had fluoridated toothpaste back in the 1940s and 50s, before fluoridated toothpaste was widely available anyway, showed 60% or higher reduction in tooth decay. After 1990, a lot of studies that are done looking at the impact community fluoridation has on reducing caries finds like 30% in primary teeth, 40% in permanent teeth. So there's still a reduction, but it's not as dramatic as it once was. And the reason behind that, again, kind of twofold. One is something we call the halo effect. So we're all ingesting fluoride from the processed foods. Processed foods have really become dominant in our diet here in the United States. So processed foods meaning fruit juices, breakfast cereals, granola bars, canned foods, even milk, foods that are processed and manufactured in plants that are being supplied by fluoridated water end up having fluoride incorporated into those food products, and then we eat them. So we're getting this halo effect from that manufacturing process in those areas with fluoridated water. But really, what has made a tremendous impact on the rates of tooth decay has been the rise of topical fluorides. And so we're going to go talk a little bit about those guys right now. So again, fluoride definitely has been proven to prevent tooth decay. And we talk about the systemic effect, mostly from community fluoridation of water, salt, or milk. But what about this topical effect? So I just thought this cute quote was so cute when it comes to toothpaste, that there are two kinds of people in the world: those that squeeze the toothpaste from the bottom of the tube and sociopaths. But toothpaste has been a wonderful, fluoridated toothpaste has been a wonderful tool for us to use when it comes to reducing tooth decay. So toothpaste, the fancy term for it is dentifrice, with the root of that being denti, tooth, and fricare, to rub. And toothpaste or dentifrices have been around for many, many years. The ancient Egyptians were the first users, and we're talking, 5000 BC when the first dentifrices were in use. But basically, a dentifrice or toothpaste is any kind of powder, paste, or gel that's used for cleaning, whitening, gum health, and now cavity prevention. So in 1956, Joseph Mueller, a dentist, and William Nebergall, I might be saying that wrong, a chemist, they actually formulate pressed toothpaste to include stannous fluoride, so a form of fluoride, and market it as this is going to help prevent cavities. And in 1960, the American Dental Association endorsed fluoridated Crest, which was fluoridated at 1,000 parts per million, because it was effective in preventing cavities. So again, that topical effect, but it's doing the same thing as far as replacing that hydroxyl ion and turning hydroxyapatite into fluorapatite and making a harder enamel crystal structure. And by the 1960s and 1970s, fluoridated toothpaste was widely used in developed countries. Fluoridated toothpaste definitely prevents tooth decay. So there have been multiple studies, it's been extensively researched and reported on, and systematic reviews that confirm that fluoridated toothpaste prevents tooth decay. You do need a minimum of 1,000 parts per million of fluoride in that toothpaste in order to have a good effect. And there is also a dose response curve. So higher amounts of fluoride are even more effective at cavity prevention and remineralization of enamel lesions. So what does that mean? That means that you could start the cavity process, right? So you have bacteria that have been ingesting and metabolizing those fermentable carbohydrates in your mouth, and they've started to punch little holes in the enamel by secreting acid on that enamel. If you use fluoride as a therapeutic, so basically requires a pretty good amount of fluoride, you can actually incorporate the fluoride into those punched out small lesions in enamel and remineralize. So you can make the start of cavities, either you can halt that process so they don't progress into larger and larger cavities, or actually some cases remineralize and reverse the decay process. And prescription toothpaste are available as high as 5,000 parts per million. There's Prevident is the most commonly prescribed form of that. But when it comes to toothpaste, and this is a big but, the effectiveness really depends on health behavior and compliance with an oral hygiene routine. So you can have a tube of 5,000 parts per million fluoride toothpaste sitting on your bathroom counter. It is not going to do anything as far as cavity prevention if you're not using it properly and on a regular basis. And so I put this little video in here. I hope that I'm able to play it. But this is actually put out by the Iowa Department of Health, and it's trying to get children to realize, how they're supposed to brush their teeth. And I think I wanted to share it because I think it's first of all, I think it's really cute. And second of all, I think I want everyone to kind of keep in mind out of how many of us diligently brush, a minimum of 2 minutes twice a day. And are we flossing and are we doing all the right things that we're supposed to do? And now you think about putting this onus on young children, especially young children, maybe who have working parents who don't even have, access to toothpaste. But let me hit the play button.
Giacona, is there supposed to be some type of sound to this video?
So that, when you think about compliance and children being expected to actually brush and use that fluoridated toothpaste appropriately twice a day, every day, I think everyone can kind of appreciate that that might not always be happening, right? Um, so let's talk a little bit about fluoride varnish. So I talked about at home, we have toothpaste, and professionally we have gels, foams, mousses, rinses with higher concentration of fluoride, typically 5% sodium fluoride, which means it's 22,600 parts per million fluoride. But the one that we are most excited about and most every dental office is using these days is fluoride varnish. So in the 1960s and 1970s, several different forms of fluoride varnish were invented in Europe. The FDA here in the US has approved fluoride varnish for desensitization of enamel, so people with sensitive teeth, but it's used, widely used, off-label technically, for caries prevention. And it's become the gold standard over gels, foams, and rinses. And that has to do with one, patient tolerance, but also the fact that fluoride varnish is a resin-based material that actually sticks, adheres to enamel, so it stays in contact with enamel longer and is more effective than things like rinses that, or foams that have minimum contact. And it's also very, very, very safe to use in very young kids because it's a very small volume and you don't have to worry so much about them swallowing the high concentration of fluoride. There was a Cochrane review, right? Our gold standards when it comes to systematic reviews, and how we go about deciding how to formulate our clinical guidelines. And they found that there was moderate quality evidence that fluoride varnish reduces decay by about 37% in baby teeth, primary teeth, and by about 43% in permanent teeth. So when it comes to actually applying fluoride varnish is not available over the counter. It really, it does require an encounter with a healthcare professional. Now, that healthcare professional does not have to be a dentist. But fluoride varnish can be applied in traditional clinic settings. It's very easy to apply in community settings, or for example, in schools or childcare facilities at community events. Dental providers, so dentists, hygienists, dental assistants, can all apply fluoride varnish, but also non-dental providers can or legally apply fluoride varnish. So pediatricians, school nurses. In 2012, New Jersey Family Care here in New Jersey actually started reimbursing pediatricians and primary care physicians for fluoride varnish applications. So when you have patients who have commercial or private insurance, sometimes there's a limit to the frequency of fluoride varnish. So the insurance will only reimburse for fluoride. Sometimes it's twice a year if you're lucky. Sometimes it's only once a year. And often there are age limits for what they will reimburse up to. So for some private insurance, and this is so arbitrary, right? When it comes to what insurance decides that they're going to reimburse for. But typically it'd be like 14 or 16, if you're lucky, 18, and then they won't reimburse for fluoride varnish anymore. Here in New Jersey, I am actually kind of proud of our state for doing this, but our state Medicaid system for children under the age of 19 will reimburse the provider that applied fluoride varnish, no matter what frequency. So if I have a child who's at very high risk for dental decay and they saw their pediatrician last month and their pediatrician applied for fluoride varnish, which was great because this kid is at high risk for decay, maybe even already has decay, and I see them a month later, I can put fluoride on and I'll still get reimbursed because New Jersey has the smarts to realize that the fluoride varnish is doing a good thing, and they want to encourage its application, especially in our high-risk children. So it's so easy to apply to the teeth. As you can see here in this slide, it literally gets brushed on with a little paintbrush. Again, it's a very small volume that you use, a small volume that actually comes in the packet. So you're not going to have a child ingesting a large amount of fluoride. Is just impossible. There's just not the volume so that they could do that. It is, as I mentioned, a resin-based varnish. It physically sticks to the teeth, so it has longer contact time with the enamel. We do give post-application instructions, and those kind of vary by provider and by the formulation of the fluoride varnish, by whatever brand that you're using. So for the most part, I usually just kind of blanket across the board tell patients don't eat or drink anything for the next half an hour because you do want that product to stay in contact with the enamel as long as possible. And again, it can be applied by allied health workers, so school nurses, hygienists, dental assistants, pediatricians. That's all totally legal and encouraged. It can really help remineralize those small cavities, the early starts to cavities. And it's also, this whole presentation is kind of focused on kids because that's where most of prevention has to take place, right, early on in childhood. But a lot of adults are experiencing root caries. So basically what happens is as they're getting older, their gums are receding and parts of the tooth that really aren't supposed to be exposed to the oral environment, and that those bacteria and those fermentable carbohydrates, like the root surfaces are, and they are developing caries on those surfaces, on root surface. So fluoride varnish is effective in preventing that. So from a public health perspective, where are we now with using fluoride to prevent tooth decay, which is, has been and still is the most common chronic disease in children worldwide. And I think as from a public health perspective, we really need to keep in mind that cavities are not just an aesthetic problem. Dental pain is the second most common reason for school absences. Children with tooth decay are 3 times more likely to have to miss school, and children with tooth decay are 4 times more likely to have lower grade point averages. And in rare instances, but truly tragic instances, like the case of Diamante Driver, tooth infections, dental infections can actually become fatal infections. And there are definitely oral health disparities. So we have a saying, and it's a saying, but it's based in truth, that 80% of tooth decay occurs in only 20% of children. And those 20% of children are primarily living in low income households. So I have here how children, the prevalence of tooth decay in young children aged 2 to 5 in low income households is almost 3 times higher than the prevalence in high income households. And when it comes to permanent teeth, in kids aged 12 to 19, it's about twice as high of prevalence of untreated tooth decay in low income households compared to high income households. And racial ethnic minorities are definitely at higher risk and have more tooth decay than non-Hispanic white children. So why is that? Well, the same with all these disparities when it comes to chronic diseases, right? We're talking about the social determinants of health. So things like diet, those fermentable carbohydrates, cheap and convenient food items are often low in nutritional value, but very high in carbs and other unhealthy ingredients. We talk about bacteria. So those bacteria, the ones that are the aggressive bacteria that take one little speck of carbohydrate and secrete a whole bunch of acid, bacteria are passed, it's called vertical transmission when it goes from mom or dad or caregiver to child, and also horizontal transmission. So sibling to sibling, or student to student, daycare center child to another kid in the daycare center, by us just kind of touching each other, sharing things like utensils or taking a sip out of the same cup. But when a parent has untreated tooth decay, their children are at very high risk of developing tooth decay early on. That oral hygiene component. So in order to do good oral hygiene at home, it really relies on health belief systems and health behavior. Not everyone is going to be, most people are not going to be compliant with what we would like to see happening in the home when it comes to home care and oral hygiene. And then there's access to care issues. So a lot of people are afraid of going to the dentist, afraid of bringing their kids to the dentist because of high out-of-pocket costs. They might be having a lot of difficulty finding providers who accept public insurance. There was actually recently a study published here in New Jersey that there were a whole bunch of providers listed on Medicaid websites so that parents could look and find pediatric dentists that will accept Medicaid. And what the authors of the study did was they called these providers, they called their offices and said, oh, pretended to be a parent wanting to make an appointment, and found out that more than half of the people listed, in fact, did not participate with Medicaid and would not accept these children into their offices. Some people just can't make it to the office. It's like maybe it's people who live out in rural areas have a lot of trouble accessing dental providers. And maybe the caregivers just can't make the appointment times because even here at Rutgers, our school clinics are open 10 a.m. to 5 p.m. And if you're working Monday through Friday, 9 till 5, it's going to be a tough ask to bring your kids to the dental clinic during those hours. So when it comes to dental cavity prevention, So in today's world, we find studies looking at water fluoridation. We see that water fluoridation is still working, it's usually reducing tooth decay by about 25%. Fluoride varnish applied a minimum of twice a year is an even greater impact. So we see about a 40% reduction in tooth decay. And sealants, which I'm not going to go into because they're not really related to fluoride, but basically they're professionally applied resin coatings over those deep grooves and fissures on permanent molars. And these are sites where about 90% of tooth decay in the permanent dentition occurs. Well, sealants can reduce tooth decay by about 80%. So that's probably our most effective weapon against tooth decay. But when we talk about water fluoridation in combination with either fluoride varnish applications or sealants or other preventive measures, we use the kind of think of as like the seatbelt and airbag analogy. Once we got airbags, we didn't stop using seatbelts. One doesn't replace the other. It's an additive effect. We want both. We want everything that we possibly can be doing and working together synergistically. So disparities, unfortunately, persist, mostly when it comes to accessing care. Again, that fluoride varnish, it's not available over the counter. You have to be able to access it. It's got to be professionally applied. Again, by a multitude of providers, from school nurses to pediatricians to the dental workforce. Dental sealants are, they definitely must be applied by a licensed and trained dental specialist, and they also require some specialized equipment. So they're not hard to do, but they're not something that is just painted on and as easily done as fluoride varnish applications. And toothpaste, when it comes to toothpaste being used at home, toothpaste costs money. And surprisingly, it's not covered by SNAP program. And for a lot of people, toothpaste might be unaffordable or unavailable. Plus, as I mentioned over and over again, using toothpaste requires a compliance with an oral health routine. So the nice thing, the lovely thing about fluoridated water is that it reaches all members of the community, regardless of household income. And drinking fluoridated water does not require any behavior change. You don't have to be compliant. It's kind of the environmental default if the tap water has fluoride in it. So now we can just talk a little bit about what happens when water fluoridation has been stopped. So in the case of Juneau, Alaska, they stopped fluoridating their water in 2007. And these authors in the study listed at the bottom of this slide used Medicaid data to come up with the results that they published. So using Medicaid data, these are low socioeconomic status children, high risk children. And we also have to think about the Medicaid data means that this was government money, right? And what they saw is that comparing 2003, when the water was still fluoridated, to 2012, 5 years after fluoridation stopped, a significant increase in tooth decay. And this translated into a significant increase in Medicaid expenditures for dental restorations. And sadly, the highest increases in tooth decay and costs were seen in the youngest children. So those children that were born into this non-fluoridated environment, those children less than 6 years old. And I will tell you, any practicing pediatric dentist will tell you, the younger a child is, the more difficult dental restorations are to do. So it's very, very tough to do fillings on really young kids. I think we can all probably understand why. And these young kids under age 6, if they need a lot of work done, they are likely going to end up needing general anesthesia in a hospital setting in order to get the dental work done. So you can imagine the resources involved in treating these young children. Calgary, Canada was another city that they decided to stop fluoridating their water in 2011. And the authors of this study, McLaren et al., compared what was going on in the population of Calgary that stopped their fluoridation in 2011, and they compared that to the population in Edmonton, because Edmonton did not pull its fluoride out of its water, it stayed fluoridated. What they saw in Calgary was a significant increase in tooth decay comparing pre-stopping fluoridation in 2009 to 10 to just a mere 5 years later, 2013 to 2014. And what they really saw too, especially comparing it to the population of Edmonton, was that there was a significant worsening of health disparities. So not only higher rates of tooth decay, but lower ability to access care in the lowest socioeconomic status children in Calgary. And what finally ended up happening was Calgary in 2021 has actually voted to reinstate water fluoridation. So why is fluoridation the debate back in the headlines in the US? Well, we've all heard about RFK for the Health and Human Services appointment. A lot of what RFK is quoting and what other anti-fluoride folks here in the US are quoting is this national toxicology report that was published. So what these authors of this report did was they compiled a bunch of studies that were done on populations outside of the US, there were none in the US, that were exposed to naturally occurring high levels of fluoride. So again, they were drinking water from springs or reservoirs where it was naturally, not intentionally fluoridated, but naturally high levels of fluoride. And they, submitted this report to like the National Academy of Sciences, and the National Academy of Sciences reviewed it and said, no, this is, you guys are, the studies themselves are flawed. There's very low quality in each individual, included study. But that the experts from the National Academy of Sciences, from the CDC, from the American Dental Association, you name it, all agree that the studies that were included in this national toxicology report really have no correlation to drinking fluoridated water, which the WHO puts at a max of 1.5 parts per million of fluoride. And here again in the US, we're even lower than that. We have 0.7 parts per million fluoride. And just as a side note, the National Toxicology Report had quite a few authors on it, but there was not a single clinician, whether that be a medical or dental professional, that was included as one of the authors. So speaking of toxicology, what else is in water? Well, we add a bunch of chemicals to water, and every single chemical added to water is carefully, monitored and added to work at that therapeutic index to keep our water safe. Most common added the chemical is chlorine, but that's absolutely necessary to keep drinking water clean and safe to drink. And just as a note, high amounts of chlorine can cause respiratory distress, GI problems, skin irritations, and cancer. And really high amounts can be very acutely toxic. And then finally, kind of wrapping it up here, if we look at New Jersey as a natural experiment, right? So everyone agrees that we really can't do randomized controlled experiments on water fluoridation. But what we have relied on are observational experiments. And that's not to say that other major advances in health haven't been made by just observational experiments and the outcomes measured in them. For example, the effects of smoking on lung cancer. Only 16% of New Jersey residents have access to fluoridated water. And here in 2022, there was a survey of third graders throughout our state that found that we had higher than national average rates of untreated tooth decay, almost twice as high as the national average. But here in New Jersey, where, if fluoride is so toxic and causes all of these problems, then we should be protected because we don't have fluoride in our water. But unfortunately, that is not the case. And we have higher rates of autism, Alzheimer's disease, and cancers, and even thyroid diseases than the national average. So why does the CDC call water fluoridation one of the greatest public health achievements of the 20th century? It's because it's not expensive. Remember, it's only about $1 per person per year. And every dollar spent on prevention saves more than $20 on avoided dental restorations. For private payers, that money saved is potentially invested into the local economy. And for those who are on public insurance, that means dramatic savings to state and locally funded health systems. Drinking water, fluoridated water, again, does not require any effort or behavior change. It's just an environmental default set for healthy behavior. And as a public health worker and as a pediatric dentist, I will say that prevention of cavities can lead to immeasurable improvements in the quality of life, and especially for our most vulnerable populations. Remember that we were looking at that the 20% of kids that have 80% of tooth decay. And I'll end with these guys here. The best dentists in the world are the ones working the hardest to put ourselves out of business. Fluoridation is endorsed by every single accredited dental school and professional health organization in the US. So we are advocating for fluoridated water. We are advocating for prevention. We are not looking to, we make a lot more money doing fillings, but we are very poor business people, and we would like to see ourselves be put out of business through prevention. And finally, thank you. I have my email posted up here if anyone wants to reach out. And I'm going to stop sharing and happy to take questions and discussion.
Thank you so much, Dr. Giaccona. That was really great and informative. We do have a few questions, some really great questions, actually. So our first question is the type of bacteria that you have in your mouth the type that's more easily causes cavities, or is a genetic factor?
So we inherit our bacteria from our primary caregivers. And again, that harkens to the vertical transmission. So we will tell moms that, it's one of the questions if you see a new patient, especially a very young child, like hopefully a 1-year-old that got the message, like we should be going to the dentist as early as age 1. We'll ask the mom, do you have cavities, or does anyone in your household have cavities? And we'll kind of counsel them on, you really shouldn't, share spoons. You shouldn't sip out of the same straw. You certainly shouldn't be licking a pacifier and sticking it back into your baby's mouth, because you do pass your bacteria to siblings, horizontal transmission, or classmates, horizontal transmission, and vertical transmission from caregivers.
Thank you. Do fluoride increase tooth sensitivity?
No, fluoride is actually FDA approved to decrease sensitivity.
Great. What are the environmental advantages of naturally occurring fluoride, and are there any species that consume it for health reasons?
I don't know of any species that consume fluoride for health reasons, besides the humans. And I don't, really, it's that therapeutic index, right? So you want to monitor the fluoride level, and to keep it at, the World Health Organization recommends between 0.7 and 1.5 parts per million. You don't really want to go above that, because then you will see, you'll certainly see an increase in fluorosis, that ugly brown modeling of enamel.
Great, thank you. Why has the New Jersey water not been fluoridated, and for how long has this been the case?
So it's always been the case. And the why would probably require another 24 to 36 hours of discussion. But it's embedded in sociopolitical reasons. Yeah, water fluoridation in parts of the world. So New Jersey is 49 out of 50 states as far as the least amount of fluoridation, right? And the only state worse than us when it comes to, or has less fluoridation than us, is Hawaii. And if you think about it, in Hawaii, you have to pipe the water, right? It's got to be water supply, so public water supplies. And Hawaii, outside of its cities, is actually very, very rural. And you think about having like some central water supplies, it's not so easily done. New Jersey, we don't have that excuse. It's totally socio-political.
Thank you for that. What should be the order of oral hygiene routine? Flossing, water flossing, or then brushing?
Doesn't matter the order as long as it's getting done.
Right. Is it better to rinse with water after using fluoride?
Technically, no. And that was in that little video, that if you're using fluoride toothpaste, and especially a prescription fluoride toothpaste, because you're at high risk and your dental provider has recognized that and prescribed a high fluoride toothpaste, we give the instructions, do not rinse after using.